Now, we've discussed a lot of things and you've seen it. All of these patients that you're going to see are patients from my own practice, and I want you to see a real world situation whereby whatever we've discussed, how it appears in the real world. And so I've taken photographs mainly of the monitors. So this is a patient where it is predominantly congestion. This is an RV dysfunction. This patient actually had an ARVD, but usually even pure right ventricular infarcts do sometimes present like this. But usually if it is an acute right ventricular infarct, the RV cannot cope with an increasing afterload, and it may reduce the LV also. In this case, this is a pure, and it's quite rare to see this, but sometimes you may have patients with poor perfusion who have been managing with that poor perfusion, but the acute slide now is mainly caused by worsening congestion. You can see here the CVP is quite high. So this is the kind of patient where diuresis or use of filter may be of value. So, you can consider even filter as some kind of a mechanical support, because it is using a pump and you are taking blood out. So, the use of a filter can also be quite effective in some of these patients. Here you have a problem in a patient who has known aortic regurgitation, who is again suddenly presented with acute on chronic. So these two things only happen. Either the patient had pain or there was some reason for his afterload to worsen, which basically means that the regurgitant fraction went down, which worsened the perfusion. But it could also mean that the overall global biventricular dysfunction is now leading to a high CVP. So here is a case of an aortic regurgitation that presented an acute heart failure. And this patient has both perfusion and congestion issues. This is an extreme case of a patient with post-CABG, many years, a vasculopath, who presented for assessment for heart failure, but then slid into very significant acute heart failure. In this patient, there is no rhythm. He's being paced. You can see his lungs are still working very well, a very low perfusion pressure, and an extraordinarily worsening right ventricular function. So this is somebody with a combined severe biventricular failure, and here there is obviously a significant component of both perfusion as well as congestion. Now this again, so this people don't tend to think of this but when you're called to assess a patient in a critical care unit, especially with respect to ECMO, you can see this. The patient would usually be called when they're not so worried about a saturation of 80-85. They're giving the patient more. They're giving 100%. They put him on NIV. They've intubated him. They've increased the FiO to 100. They think that they prone the patient and all of these things. And suddenly they have a rhythm problem and the patient arrests. So this is because of two things. One is because obviously less oxygenated blood is going to the myocardium. And the myocardium is one that really requires a lot of oxygen. It requires the most amount of ATP, has the highest amount of mitochondria in its cells. And so it is going to be the one that suffers the most because it is trying to convert chemical energy into mechanical energy. But secondly, the hypoxemia worsens the pulmonary pressures. It increases the pulmonary vasoconstriction. And now you have a right ventricle that is not adapted because this patient had a pneumonia or ARDS or COVID or whatever it is, or a pulmonary embolism, whereby the pulmonary embolism, there is an additional factor for increasing the right ventricular afterload. So you have a worsening right ventricular afterload in these patients, and the RV is now contracting, but it doesn't even have enough oxygen to contract. So this quickly sets up a spiral. Usually it presents as VF, and these patients go into cycles of VF. So one of the ways is the knee jerk in these patients, especially in the kind of crashing, is to go on a VA ECMO. But with my experience of almost 10 years of doing these ECMO patients, we have over 225 patients that our team has dealt with. Just initiating a VV ECMO in most of these patients usually stabilizes these patients. So you can always escalate it to a VA, but if you can maintain it on VV, then these patients usually do very well. Now, the reason I put this slide up is the patient may present first into the ICU itself with this kind of a cardiac dysfunction, and it is very reasonable for you to mistake this to be a primary cardiac problem. So even before the diagnosis, if you see a desaturated, usually the heart can compensate, and as long as the lungs are well, desaturation is an unlikely sign. Of course, at the very end of acute heart failure, you can get desaturation with very poor peripheral flow, especially because the SATS machine is not picking up in a very cold hand. But a primary respiratory problem is a diagnosis that is very well worth taking some few minutes to make at the bedside, especially when you're contemplating ECMO. Now, this is a patient who had primary pulmonary hypertension, was awaiting on the list and developed pulmonary embolism. And this is a severe combined cardiorespiratory failure. This is very unlikely to just improve because this patient has, he was waiting for a combined heart-lung transplant, had short LV, RV, everything. So therefore, these patients will usually require full VA ECMO in this situation.